Thank you very much. Happy to be here. I'd like to talk a little bit about ablation of liver and kidney. Just bear with me one second as I advance the slide. Here are the disclosures, and the next slide lists the indications. These slides should be available for you to peruse in more detail if you like. So for liver ablation, which we'll start with first, our goals of treatment are essentially to achieve surgical margins. And so 5 to 10 millimeters is what we go for, basically because we want to address the microscopic disease that is invariably there histologically if we were to take a resection sample. And so getting a 5 to 10 millimeter margin reduces risk of recurrence from microscopic disease. And this has been shown. And as a result of that, a 2 centimeter lesion really requires a 3 to 4 centimeter diameter ablation zone. And you can imagine a 2 centimeter lesion is fairly small. It's about as small as we are fortunate to see, yet we need a relatively decent ablation zone in order to adequately cover that lesion. So what are some of the things that influence whether we can achieve that ablation zone? Well, first, it's the location of the tumor. And second, there are other things involved inside a very vascular organ like the liver, such as the heat sink, which many of you have likely heard about. But that's essentially a cooling effect of large blood vessels near a lesion, which effectively reduces your efficacy of ablation. This is more concerning for radiofrequency ablation, and that's why traditionally it's been a big issue in the liver, less of an issue with the rapid heating of microwave, and essentially a non-issue for non-thermal techniques, and we can talk a little bit about that moving forward. So what is microwave? Well, it's essentially in many ways like radiofrequency. It's in the radiofrequency spectrum. It applies an alternating electromagnetic field, and it creates rapid oscillation of water and ions to generate heat. It works exactly the same as the microwave you might have in your kitchen, for example. So the field is broadcast through the antenna, which is the needle, and it's not limited by tissue desiccation or charring, which can be some of the limitations of radiofrequency. And so therefore, we can achieve larger ablation zones, and this rapid heating is relatively more resistant to heat sink effects. So why hasn't microwave been around for the same history, say, as radiofrequency? Well, it actually has, but it's been limited by some of the technology, and the modern antenna design is really what's advanced the capabilities of microwave in the clinical setting. So, for example, there's shaft cooling, which limits this comet tail effect, which has traditionally been an issue with microwave, where the energy propagates backward along the length of the antenna. And this enables more of a spherical ablation zone. The modern antennas are also very small and very visible by both CT and ultrasound. And the higher frequency antennas in particular are able to generate high power, which is good for vascularized tissue, and it also gives a slightly more controlled ablation. So here's an example of the effect of shaft cooling in a benchtop model. The upper panel is a non-shaft cooled antenna, and you can see that long tail, that teardrop appearance, which is that comet tail effect with the heating traveling up the shaft of the antenna. And the bottom image is a shaft cooled antenna, which basically minimizes the propagation of heat along the length of that shaft. So you still get an oblong shape. However, it's much more spherical with less of that comet tail, which, as you can imagine, makes it safer as well. So some of the considerations when you're actually looking at a lesion and deciding what to do is what is the lesion-specific characterization or characteristics of the tumor that you're going to ablate. Is it a large lesion? Is it a small lesion? Is it relatively spherical? Is it amorphous? And some of the factors that you can use to influence that are the number of probes you use, the power, and the time of ablation. And a lot of that depends on the anatomic structures at hand. So here's a graphic of the energy that's applied when you use antennas with synchronous energy deposition as opposed to asynchronous energy deposition. On the left, if you had just 3 random antennas and the energy is not essentially communicating with each other, for lack of a better word, you get these very focal zones of ablation, and these spaces in between that are relatively less influenced by the energy that's being applied, whereas on the right, you can see when the energy is applied in a synchronous manner, meaning if you have 3 probes in this panel here, those 3 probes are actually communicating with each other and synchronizing their energy so that you don't get signal decay and signal blockage with the energy deposition. You get much more, not only an obviously more spherical zone of ablation, but if you see the sort of energy parameters, they stay a lot more consistent and are deposited throughout that larger volume. There are 2 different styles of antenna that are present with the NEUWAVE system. This is the LK and LN probes, which were one of the earlier iterations of the probes. You can see the energy is emitted through not the very distal part of the antenna, but slightly far back from the very tip. And the energy is propagated both anteriorly or forward and backward along the shaft of the antenna. And this generates relatively large ablation zones for each respective antenna. The newer design is the PR probe, which works slightly differently. The emitter is also near the tip, and the energy primarily propagates backward from the tip rather than forward from the tip. So only about a couple of millimeters from the tip does any of the microwave energy move forward, and it mainly builds and grows backward. And this is important to consider when you're placing your probe. It gives you certain safety features, certain ideas. It's very reproducible. And that's why it's called the precision probe, because it is very reproducible. But it also has implications in terms of how you position the antenna within the lesion itself. And we can give an example of where that might come into play in a minute. I would say probably by and large, the PR probe has become probably the most popular probe that certainly that we use, just because of that reproducibility and its controlled energy at the tip. So in terms of guidance techniques, obviously, this can be very personal. It can be very much dependent on the tools available and the tools that are most effective for each patient. CT guidance is very common and very popular to use. You can see the probes are very visible by CT. If you give contrast, you can certainly see the lesion respectively relative to your probe. Or if you have recently treated with chemoembolization with Lipiodol, for example, that deposition of Lipiodol can be a nice marker for CT guidance. Ultrasound is very popular as well. It gives you some real-time guidance. There's the lesion there, and there's the trajectory of the antenna into the lesion. Personally, I like ultrasound because it gives that real-time feedback in terms of lesion and probe positioning. And I like to, when able, I like to use ultrasound primarily with CT as confirmation. And I always do CT as confirmation because obviously you can get some averaging with either technique. So I like to use both. Cone beam CT, as cone beam is getting faster and better, that's certainly an option as well. It keeps everything in the angio suite where you might have most of your other equipment and your nurse and tech staff that you like to work with. Cone beam CT is certainly an option. The patient has to be able to hold their breath a lot better. It's a little less forgiving than CT. The resolution isn't quite as good as CT, but if you have good inherent lesion and tissue visibility and contrast enhancement, cone beam CT guidance can definitely be a good option to use. And then a combination of all, and I kind of alluded to that. I really like to use a combination of ultrasound and CT guidance for optimal positioning of the probes. So here's an example of a lesion in segment 7 of the liver, hyperenhancing, and that's the delayed phase with a pseudocapsule around it. This is hepatocellular carcinoma. And we place the probes, we use contrast to confirm appropriate probe positioning, and this is immediately after ablation with contrast enhancement. You can sort of see the ablation zone, and the hypodense lines are track ablation technique, which we like to do after every ablation. The probes themselves, the energy, the generator has a track ablation mode. However, the probes themselves, they stay hot for quite some time after the ablation. And so there's another technique you can do for track ablation, which is just a hot needle withdrawal. And that's also a very effective way to do a track ablation. We like to do track ablation both to prevent seeding as well as to optimize hemostasis. So it's a good technique to use. But anyway, the main point of showing this slide is because, especially early in your experience when you're using microwave, especially if you haven't used it before or are new to ablation, I suggest doing this on-table contrast enhancement for the post-scan. It'll give you more familiarity with your tools. It'll give you a sense of what kind of ablation zones you can expect depending on what kind of energy and time you've input in the generator. For example, you'll see what a 65-minute ablation at 5 minutes would look like versus a 65 watt ablation at 5 minutes would look like versus a 65 watt ablation at 2 minutes versus a 90 watt ablation at 5 minutes, for example. So it'll give you an idea of what type of ablation volumes to expect and give you more comfortable, maybe make you feel a little more comfortable with what to anticipate. Some people routinely do a post-contrast scan. Personally, we don't do routine post-contrast scans, but only if we're concerned about a margin, we would do it. Now with the ablation confirmation software that's available with the system, that's an additional incentive to have on-table contrast used to really kind of confirm your ablation volumes and can be very effective. So here's the lesion again, pre-treatment, and you can see here's our 2-month post. We get a very nice ablation zone surrounding the lesion itself. There's kind of the ghost of the lesion, and you can see this ablation zone very much mimics at 2 months post-ablation, the ablation zone we got immediately after ablation right above it. So this type of confirmatory post-contrast scan will in fact give you a very good idea of what type of ablation you actually achieved. The other thing I'd like to point out here are these two areas. You see these two large vessels around the periphery of our ablation, and you can see the ablation zone is a little bit blunted in both of these locations. And this is an example of the heat sink in effect. And you could see how, especially towards the more peripheral aspects of the ablation, where the energy may not be depositing quite as rapidly, that heat sink can be a little more influential. So something to consider when you're planning your ablation. If you have big vessels close by, you may want to sheet a couple of the antennas a little bit closer to that margin just to ensure that you're able to achieve that 5 to 10 millimeter margin goal that we discussed earlier. So I'd like to spend a few minutes discussing some advanced liver ablation techniques. Probably most people tuning in are somewhat familiar with ablation in general and have actually performed several ablations in the liver. The liver is very common for doing ablations with people who are getting their feet wet with ablation. And so for those of you who are looking to push the boundaries a little bit, some additional challenges exist with subcapsular lesions that I'd like to just address some of our strategies to manage. So here's a common one that I get asked about a lot. It's a subcapsular lesion adjacent to the stomach and the body wall. And how can we safely ablate this without injuring the stomach, without burning the muscle? There's a very nice technique that I use quite a bit, and that is hydrodissection. So here's that lesion after chemoembolization. We like to do a lot of dual combination treatment, especially depending on the lesion of origin, but oftentimes with HCC, for example, we do chemoembolization followed by ablation. With the larger tumors, we feel it helps improve the ablation efficiency. With the smaller tumors, we feel it helps with our targeting. So I show this just to explain why this tumor is so bright on that picture on the right. That's after chemoembolization. And then here's our hydrodissection fluid. Now, hydrodissection is relatively straightforward. Once you get the hang of it, it's something that we employ quite a bit. We have a very low threshold for using it because the benefits are far greater than the minimal amount of inconvenience in adding an additional step to your procedure. Basically, we use a 2% contrast solution, so that's 10 cc's and 500 cc's of either normal saline or D5 water, and that puts just enough contrast in the fluid so that it's visible. If you don't use any contrast, that's fine if you're predominantly using ultrasound guidance, for example, but if you're using CT guidance, then the water, the density of the water will oftentimes obscure the density of the structures that you're actually trying to identify. So we add a 2% contrast solution so we can identify it. And you can see here how nicely, not only has it pushed the stomach back, but it also has pushed the lesion away from the body wall. And this enables us to be as aggressive as we want to be with that lesion without worrying about injuring adjacent structures. Here's another structure, a lesion that's adjacent to the kidney and the IVC. And from a positioning standpoint, you might want to come from this anterolateral approach, and it might seem cumbersome to put a needle in for hydrodissection of the kidney away from the liver capsule. However, you're just using tiny needles. Here we'd use a 22 gauge needle, and you can actually go directly through the liver to the Morrison's pouch area and put the hydrodissection fluid in that area. And again, feel very confident about doing your ablation without sacrificing any adjacent structure. And here you can see afterward, we get a very nice ablation, no injury to the adjacent kidney. Here's a tricky one that at first pass may not seem tricky. It's a lesion in the right lobe of the liver, seems like a chip shot for all intents and purposes. However, I'm a big fan of using all planes and all reformations when planning an ablation, because oftentimes you'll see that a lesion like that is actually a subcapsular lesion and it's right up against the colon. And the areas of the body that I'm very concerned about are the retroperitoneal structures, the colon, the duodenum. These are relatively less mobile structures, and so as you start the ablation, if there's a component that's adjacent to your ablation zone, it could be very easy to get injured. So, excuse me, I have a low threshold to employ hydrodissection in this setting. Again, we take the extra effort, very thin needle. Ideally, you put your hydrodissection needle right between the lesion and the structure you're trying to move away, and that's the most effective way to do it. It really has to be right there at the tip where you want to be, because otherwise the fluid can diffuse elsewhere. Once you push the colon out of the way, then you can be as aggressive as you need to be. Here's another example of a lesion against the body wall. Again, once you get used to hydrodissection, here many people would not do hydrodissection here, but to minimize the risk of injury to the diaphragm or even irritation to the diaphragm, which could be probably the biggest source of post-procedural pain, we just go ahead and put a little bit of fluid in there. You don't need a whole lot in this location because of the movement of the liver, and that allows us to do the ablation, get all the way to the capsule without risking any injury to the adjacent diaphragm. And you can see there's no thickening or injury to that diaphragm there at the follow-up mark. Again, another lesion adjacent to the stomach. Sometimes you try the hydrodissection and the fluid just diffuses away, like in this circumstance. Here we even put an NG tube down to try to decompress the stomach out of the way. That's another maneuver that you can do. We often do it, but in reality, it's really the hydrodissection that does the trick. If the hydrodissection fluid, if you're able to create it and create that buffer where you want the ablation to be, but it tends to diffuse away, then what we do is simply push in the hydrodissection fluid throughout the ablation, nice and slowly through a large syringe. We just gradually infuse the hydrodissection fluid, and there you can see the tip of the hydrodissection fluid just gradually pushing the fluid around that margin. And especially with microwave, you're only talking about minutes of ablation. It's not like with RFA where you're ablating for, several minutes, 20 minutes, 16 minutes. Here with microwave, your ablation is done in 2 to 5 minutes essentially. And so you can easily infuse the fluid during the ablation to protect that stomach. Here's an example of a situation where we in fact had to do that technique, and you can see we're able to ablate all the way to the edge of the capsule to the edge of the lesion, and there's no evidence of any injury to the stomach at follow-up. So, and then finally, there are some lesions that hydrodissection doesn't work for no matter what you do, and there are some alternative strategies to use in that setting. Here's a lesion that's adjacent to the colon in the right lobe of the liver, and despite our best efforts, we tried to push fluid in there, and the fluid would just diffuse away and the colon wouldn't move out of the way. And so finally, we're able to do another separation technique, which we've used several times with success, and that's a balloon separation. And basically through that access for the hydrodissection, we can upsize to a sheath and advance a 10 to 12 millimeter balloon. We use a high pressure balloon just for the extra fabric, and that pushes the colon directly out of the way mechanically. And then we can do the ablation, and here's the follow-up. You can see that lipidol stain staying within the lesion after it's been ablated, no injury to the associated colon. Once you get facile with these techniques, sometimes before you've had a chance to use them, there might seem to be a large activation energy to actually employing them. But once you've used it a couple of times and you see it's feasible, you can definitely do it, and it will open up a lot of lesions to you that you otherwise might think are not good ablation candidates, or you may decide to do a different treatment modality. I'm a big fan of ablation. I think in terms of our IR techniques, it's the most definitive therapy that we have in terms of outcomes. So I try to use it whenever I can, and some of these techniques will just simply make more candidates available for ablation. So here's the lesion adjacent to the pancreas. Obviously retroperitoneal structure, not easy to push away. We tried with fluid. You can see there's fluid there, but it's hard to get this to separate, and so a balloon separation technique worked very well. You can see the ablation zone goes right up to the capsule. No evidence of pancreatitis either by imaging or clinically afterward. And then the gallbladder I get asked about a lot as well. Lesions adjacent to the gallbladder, how to handle that. And different people have had different strategies for this. Some people do chemical ablation along the margin of the gallbladder, and then microwave ablation to the remainder. Some people do non-thermal techniques, but I think you can definitely do ablation of these with thermal energy. This is a lesion that's adjacent to the gallbladder. The gallbladder is filled with contrast because of vicarious excretion. A couple of maneuvers you can try. One is to give cholecystokinin to cause the gallbladder to contract. We do that every single time. I can't say I've actually ever seen it work, but we do it every time just because it's an easy maneuver to try. You can actually do hydrodissection of the gallbladder fossa, and we've tried that and been successful at it to give a cushion of fluid around the gallbladder itself, between the gallbladder and the lesion. And then finally, balloon separation again if all else fails, but it enables you to be aggressive and to treat these. Now, what about high lesions? High lesions near the dome. Some people are somewhat intimidated by them. They can be technically more challenging. Actually, the technique of hydrodissection itself was designed to push the liver dome down in order to create an ultrasound window for ablation. That was actually the primary reason that hydrodissection was created, not as a protective maneuver, but as a liver displacement maneuver for more ease of visibility by ultrasound. This was when ultrasound was a primary modality used for ablation guidance. So that remains a very good technique for dome lesions. You might have to put up to 1 liter of fluid in, but it certainly brings the dome into better visibility and allows you to target dome lesions. And again, I'm willing to push that boundary because ablation is such a good technique for many of these lesions. And there's another technique which again sounds intimidating before you have a chance to use it, but once you have a chance to use it a couple of times, it really you realize how helpful it can be. And one is induction of an artificial pneumothorax. So here's a 2-centimeter lesion at the dome, very high, and that's on a diagnostic CT when the patient has taken a deep breath in and it actually pushes the lesion further down into the abdomen. Once they're under anesthesia or sedation and their tidal volumes go down, that liver just goes right up into the diaphragm, right up into the chest, and before you know it, there's lung everywhere you look, unless you take a really steep subcostal angle. So either you can give a lot of fluid and push the liver dome down, or there's an alternative technique of actually inducing an artificial pneumothorax, where basically you push the lung out of the way with air, and that enables you to go transpleural directly into the lesion without going through the lung. So transpleural without being transpulmonary, and then at the end you just aspirate out the air, and there's no pneumothorax. So there's a couple of things to consider for a procedure like this. First, you want to use a Metapore, a 22 micron Metapore filter before you put room air into the lungs so that no particulates get into the chest cavity. Usually I'll use ultrasound and a micropuncture set and get right to the pleural's edge using a linear transducer where you can see it very clearly. I'll give a little bit of fluid there, essentially to create a small pleural effusion to enable the micropuncture sheath to get into that space. Once the micropuncture sheath is there, then use a large syringe with the Metapore filter on there and basically slowly put air into that lung. Obviously, if you're working with an anesthesiologist, you're going to want to tell them that you're going to drop the lung. You don't have to drop the lung all the way, but you give about 500 cc's of air and the lower lobe basically just collapses out of the way, and you're able to position your probe directly into the lesion, do your ablation. When you're done, through that same micropuncture sheath that's in there, you can aspirate all the air out until the lung has fully expanded, and you can even use positive pressure if you want with your anesthesia colleagues to help reinflate that lung. But there's no pneumothorax. Even if there's a sliver of air left from what you've introduced, that gets absorbed very quickly. So it's not a pneumothorax in the sense that you've actually punctured the lung, which is the more dangerous pneumothorax, because then there's a hole in the lung that needs to heal. Here, there's no hole in the lung. You've just simply pushed the lung out of the way specifically to prevent a pneumothorax. So this is a very useful technique to use. Now, just a minute regarding the ablation characteristics to expect. If you recall, the PR probe, which is a very popular probe right now, it's probably the most common probe that we use, burns from the tip backward, and that's important to consider in terms of where you position the probe within the lesion itself. Now, if you can see, it just even in this cartoon, the widest point of this ablation zone is actually within the middle of this probe. So it's not at the very tip. And the reason why that's important is because you really want to skewer your lesion. You want the tip of the probe to go through the lesion if that lesion is a small one, say 1 to 2 centimeters. Obviously, if it's a bigger lesion, 3-4 centimeters, then you're going to need the entire width of that ablation zone, but you want to take advantage of where the width of the ablation zone is, where you position that probe. So here's an example early on in our experience. Tiny little lesion. You can see it's very dense because of the lapiodal deposition from prior chemoembolization, but I use this because it's a nice illustration of the phenomenon I'm trying to explain. So there's a tiny lesion. You can see by CT guidance, we thought we got right into it. And in fact, we did get right into it. However, you see just the very tip of the ablation probe is in that lesion. And so we do the ablation there, and no surprise, look at what the ablation zone looks like. It's a very oblong ablation. Now, this was an effective treatment for this tiny little tumor because it was so small. But if this were any bigger, then we really would have not taken advantage of that full size of the ablation zone that achieves. So keep in mind that shape of the ablation zone to expect. If we were to do this Again, we would have gotten much deeper with that probe in order to essentially center the ablation zone along the center of that lesion. And that's really kind of the key there. So we'll move on from liver ablation to renal ablation. And there's some additional factors with renal ablation to consider that are unique to the kidney, but you'll see that a lot of the same principles basically apply between liver and kidney. And a lot of people, if you're used to doing liver ablation, transitioning to renal ablation is relatively straightforward, or if you've used other technologies in the kidneys for ablation and you're interested in applying microwave, you know, and seeing what the outcomes are, seeing how it behaves, how you like it, you know, it's really not a big leap to transition to doing microwave in the kidneys. So here's a patient who has multiple cysts in their kidneys, however, one solid enhancing lesion. And you can see all the same principles apply. There's the colon nearby, so we're going to want to have to deal with that. We want to get the 5 to 10 millimeter margin of ablation, just like in the liver for the microscopic disease. With renal ablation, we do biopsy. According to AUA guidelines, you want to biopsy either before ablation or at the time of ablation because you want to know exactly what it is you're dealing with, what the grade is. So we do biopsy at the same time. And a lesion like this is fairly straightforward. You know, one of the reasons why I like microwave in this setting is because with a single applicator, I can take care of a lesion this size without having to do a lot of futzing around with different probes, with multiple probes. You know, just a single probe, put a needle in the space around the kidney just to get that colon out of the way. And you can see how very nicely just a little bit of fluid gets that colon out of the way. It gives you a lot of peace of mind. You don't have to worry about injuring the colon. One applicator in the lesion and you're done. Now, this is not, you know, there are, look at the trajectory of this needle into the lesion. It looks great, and it worked out great in this case. This was, if I had a different capability to do a different trajectory, I would have, for a couple of reasons. And this is one area where microwave in the kidney is a little bit unique relative to microwave in the liver. First of all, and this is out of the group from Madison, Wisconsin, who has published their outcomes with microwave in the kidney, and they noticed that they were getting some uranomas when they were positioning their probes in this direction. And with the probe aiming at the collecting system, there's a chance of actually getting a uranoma from piercing the collecting system. And why is that? That didn't happen in this case, so we were fortunate. And sometimes you have no choice because you're limited by your anatomic constraints. But if you can avoid going directly into facing the collecting system, it's optimal to do that. It's better to come tangential. And one of the reasons is that the microwave tends to desiccate the tissue. And during that desiccation, you get shrinkage of the structures around there and a pulling in of the adjacent structures. And you certainly see that in the liver, and we didn't really focus on it during the segment on liver ablations, but if you pay attention while you're doing liver ablations, you'll actually see a desiccation of the nearby structures. And so actually your ablation zone is a little bit bigger than what you measure because some of that tissue around the ablation zone has been pulled into the ablation zone. But one of the thoughts is that if you have the tip up against the collecting system or maybe partially tenting the collecting system, as that tissue desiccates during the ablation, you can actually pierce the collecting system and cause a urine leak to happen. So that's one reason why it's best to avoid directly puncturing the tumor towards the collecting system. Another reason why this is less than optimal if possible is any chance I get to avoid poking the tumor directly, I will take it. And that's because lesions don't have normal blood vessels. They don't have the same structure to their blood vessels. Their blood vessels are more friable, more fragile, and potential bleeding risk is higher. And one of the nice things with microwave ablation in the kidney is this cautery effect of the thermal ablation, which gives you a little additional peace of mind as well. So I have the lowest threshold to use microwave if patients on anticoagulation or antiplatelet therapy, for example. So that's one of the benefits. But for those two reasons, I try to avoid poking the lesion directly, and I try to avoid a trajectory that's aiming at the collecting system. But you can see in some cases, you can't avoid it. And we take what we get, and usually it's not an issue. But sometimes you'd have to go through the tumor directly, and fortunately in this case it worked out great. You can see here we get a nice ablation zone, and here's the adjacent colon with no evidence of injury, and you get this halo around the kidney, which is very typical after microwave ablation with this ablation zone. And ideally you get a full thickness. That's what I like to go for, essentially the equivalent of a wedge resection. And that's what I'm trying to achieve with renal ablations. Here's another situation. This is a patient that had a lesion here in their left kidney, and after treatment there was a little focus of recurrence, and they came to see me, and this seemed like the perfect lesion for microwave ablation. First of all, we want to take advantage of this oblong shape of the lesion and orient our probe along the long axis of the lesion. And again, every time I can do that, I will, especially in the kidney. If there's a long axis to the lesion, then I try to plan my ablation so that I'm going along that long axis here. Collecting system was nowhere close, so I didn't, that wasn't a factor. Not a lot of hydrodissection involved here because the kidney was already plastered against the body wall from their prior surgeries. So this was a relatively straightforward case for microwave ablation with a very nice outcome. Here's another lesion with a very central tumor. And central tumors are probably the most challenging for us in terms of ablation for a couple of reasons. Because of the central location, we tend to be a little gun shy with how aggressive we can be with the ablation. And the central location also is relatively protected with a lot of vascularity and more heat sink like we talked about. However, central lesions are treatable. And again, this is one of those circumstances where once you get familiar with your tools and your capabilities, you start to feel a little more comfortable being more aggressive. Here's a situation where with a central tumor, you might have to give contrast during the ablation to really identify the margins of the tumor because it's not sitting exophytic off of the parenchymal edge. So here's our ablation. Immediately after ablation, you can see the zone of ablation has a hypodense structure along where the contrast was given, again, to kind of confirm that we've in fact covered the lesion. If you haven't covered the lesion, it gives you an opportunity to take care of it right then and there. So there's the other sort of real selling point to using contrast on the table, especially early in your experience, and especially if you have the ablation confirmation software, because it really helps you to decide if you have an adequate margin and if you are in a position to take care of something right then and there. The other thing to consider with central renal tumors is something called piloperfusion, which is an advanced technique where you need your colleagues in urology to help you, but basically through a ureteral catheter, you provide perfusion into the renal collecting system with cooled saline, and that helps protect the renal pelvis and the ureter from injury. And actually, you can treat lesions that directly abut the ureter in that situation and be as aggressive as you need to be without worrying about injury or stricture to the ureter. And that's certainly a technique that we use often if we're anywhere close to the ureter or the UPJ. So here's another lesion that's along the medial aspect of the right kidney there. Here's another technique that some people like to use. We don't use it that often, but if you do, you can see CT guidance, and this is the trajectory I would prefer for a lesion like this. You can see we could have come posteriorly directly into the lesion, but because of the two reasons I mentioned earlier, one, avoiding direct puncture of the lesion, and two, being tangential to the collecting system rather than aiming at the collecting system, this is really the preferred trajectory for microwave ablation using the NEUWAVE system in the kidney. And one of the other reasons I'm highlighting this case is we actually did a CT during the ablation. And some people will do that. They will get a CT scan during the ablation. What you expect to see with CT guidance as the ablation is actually happening is the gas from the ablation, sort of these vacuoles of gas being formed from the thermal energy that's being created, filling the lesion. And so this is sort of an additional on-table confirmation of the energy being appropriately deposited within the lesion itself. So you can see, you know, this is a reasonably sized tumor, and with a single applicator at a relatively quick ablation time of 5 to 10 minutes, we can take care of that. Here's immediate 1 month post. You can see a lot of inflammatory change around that kidney. The pelvis is far away. And then here's 10 months later, and we get that effect that I like, that full thickness defect. You see an atrophy of that same segment. Very nice result here. And again, no injury to the adjacent ureter. There are some guidelines in terms of lesion size that you can use in terms of how many applicators you would need. You know, I think in the University of Wisconsin-Madison experience, they talk about, you know, basically 1 applicator up to 1 centimeters, 2 applicators, you know, when you're 2 centimeters or greater, and essentially 3 applicators when you're 3 centimeters or greater. You know, it's just a rough rule of thumb. In reality, a lot of that changes depending on, you know, the lesion at hand. And so you'll ultimately have to make a decision based on your pre-procedural planning. There's no hard and fast rules. But essentially with a 5 to 10 minute ablation, you get a very nice outcome very fast. And it's a very nice tool to have in the kidneys. And so with that, we discussed some of the basic principles behind liver ablation, some of the strategies that are important to consider when thinking about ablating the liver, some of the unique aspects with microwave in the liver. I would say microwave has become the dominant ablation modality in the liver because of its ability to generate larger ablation zones relatively quickly. And we've also talked about microwave ablation in the kidneys, which is rapidly growing in popularity, again, because of the efficiency component of it and some of the unique aspects of using microwave energy in the kidney with respect to probe positioning and some of the pre-procedural planning steps involved in that. And then we brushed on some advanced techniques both in the liver and in the kidney in terms of protecting adjacent structures. But I encourage all of you to give this a chance and a try in the liver and kidney. Start with the easy lesions so you get a feel for how everything works. Give contrast at the time of the procedure so you have a sense of what you're working with, and you can correlate your post-ablation findings with your follow-up findings, and then that'll give you the confidence to push the boundaries and be more aggressive and be able to deliver this technology to more and more of your patients. Thank you very much.